but I do want to set the stage for why her voice is one we need to hear and listen carefully to. We continue to be deeply anchored in this precarious situation. Clearly, there are no immediate answers, but we should not let complexity inhibit our capacity to care. We should also be concerned about how some in our community and elsewhere remain seriously misinformed about what is happening at the level where lives are lived. Risk factors for homelessness, like substance use disorders and mental illness, have been confused as the causes of homelessness. They are not. Homelessness, as a recent book title proclaims, is a housing problem, and we need more housing. A chronically underfunded, understaffed, and fragmented behavioral health system should not lead us to punish folks expressing their behavioral health condition. On-the-ground efforts to support drug user health should not be dismissed nor discounted because they are not tied to the false promise of mandatory treatment. And not having enough places to bring folks inside should lead all of us to ask why we continue to move folks around outside, even as studies clearly show it is both more harmful and more costly to do so. It is challenging. It is challenging for sure for those who show up every day to do this work amidst a backdrop of voices disconnected from the very real human vulnerabilities experienced and expressed at the level where lives are lived. And so this, my friends, is why we need to hear from voices of clarity that help us understand why public health and public safety are not separate conversations or competing policy priorities. Now, more than ever before, we need to lean in and listen to voices that can get us focused, laser focused on how and where we should invest our community resources, on not just the kinds of services we need more of, but also the manner in which those services should be carried out in partnership with those on the receiving end. This is how we can together start bending the long moral arc of the universe back towards justice. And this is why I'm excited to introduce our keynote speaker, who has traveled all the way from our nation's capital to be with us today. Please give a warm welcome to Dr. Kima Joy Taylor.
Wow, that was a great introduction. I hope I live up to it. Really, I want to thank everyone for having me here today. And I was going to start my talk in a different way, but I actually want to take a minute because I want to diverge from that point and really move back to the idea of roots of recovery. And roots are usually these complex sets of structures that are underground that feed and nourish plants. And I really want to take this moment to think about the roots. My interactions with the ETS staff made me really certain that I needed to start with the roots of policy. The roots needed to change the way the world moves from a punitive to wellness model for people who use drugs. People are those roots. People like the ones who are working at ETS are the roots who bring structure and nourishment to individual system structures that are needed to create positive and equitable change. They're not monolithic, very diverse, struggling between work-life balance, questioning, but anchored by caring, kindness, and love. And that nourishes a different vision for the world. So I really want to state how impressed I am with those roots, give pause to honor and thank them for talking to me and sharing from their heart for the heart and care they give to people each day. And you'll know I'm struggling because I talk really fast. I'm really trying to slow down. If I start talking too fast, raise your hand. So to start my actual speech though, when you desire change, you have to have a goal. And I want to give you guys the goal that I'm thinking about. I feel the goal has to be big enough to affect said change. And if you seek equity, well, that has to be embedded in the goal as well. Almost all goals require incremental steps, as much as that pains me. But what you ultimately achieve is as broad or as narrow as the goal that you define with that equity embedded. And I'm gonna keep embedding that. So the goal that frames this talk in my mind is a goal of equitable access to and outcomes from a culturally and linguistically effective, non-punitive, community-based, integrated physical and behavioral health and social services so people are well as they define wellness for themselves. This goal is achieving with and by people who change individual lives and systems. To achieve this goal really requires looking at our past, our present, and future. How did we, do we, and will we treat people, and particularly people who use drugs? To frame the talk for me, I'll let you know I've had a lot of different jobs and a lot of different vantage points and perspectives on how to promote equitable access to and outcomes from health and other systems for people who use drugs. I also should note that one of those jobs is program officer at Open Society Foundation, in which I was an early program officer at the initiation of the LEAD project. And so I'd come out to Seattle then and had met ETS then, which is why I'm so honored and excited to be invited back. So I'm going to start with that history idea, and I'm going to start with the idea of we're in roots of recovery. And since this is a roots of recovery event, I originally planned to Google, keep moving from the mic, I originally planned to Google CMS's definition of recovery and use that as a basis for my speech. But when I was Googling, I actually found something that I thought was much better for the purposes of the talk I want to give today. And the Google definition was the action or process of regaining possession or control of something stolen and lost. So this talk is going to be about how and why systems must change and recover to regain possession of something stolen or lost, or I would say in this case, never had. And by this, I mean the health and social response to drug use that emphasizes wellness of individuals, communities, and families. We lost this central idea, we gave away the central idea that people who use drugs, like all of us, deserve a response that is used to enhance wellness. So to talk about system change, you have to admit and reckon with the history. And I know that all of you, most of you, and if you don't, I can give you a history lesson afterwards, but know about drug policy history and its racist background. You know about the San Francisco opium dens and how drug policy was really used to exclude and harm and pull out of the labor market Chinese immigrants. Same thing around marijuana regulation, use, harm, exclude Mexican immigrants from the population and labor markets. War on drugs, excluding Black and other and Latinx folks from punish them and put them in a criminal legal system. Really not just the criminal legal system though, created a punitive infrastructure in child welfare, education, employment, all of these systems that punished and took away the rights and the well-being of people who use drugs. And it's always this thing, and I find it interesting, we always say, is culturally and linguistically effective treatment better than a criminal legal system? Yeah, because this is a health and social concern. And so health and social issues are actually improved by health and social responses. I do research and have research that says, is treatment better than prison? Yeah, if you're not offering anything in prison, why are we funding that research? Yes, you are going to get better outcomes if you actually provide something that serves people. So knowing all this time that addiction is a health concern, and to be clear, we've known that since Benjamin Rush, the slave-owning signer of the Declaration of Independence, who was also a doctor, noted that addiction was a chronic health concern. We've known this, and we still stole wellness and denied a health response and forcibly used punitive responses and racist tropes to harm people who use drugs. So you know the history of drug policy. And again, if you don't, I'll be here, we can talk. And you know its racist tendencies, and you know the disparate outcomes that it produces. But of the drug policies and the systems it produces, and as you guys know, when you create LEAD, there are ways to think through changing that criminal legal response and turning it into more of a health and well-being response. But I would argue that does not really happen as effectively as we may hope if we don't include the healthcare system. So this conversation is going to take us to the healthcare system and its failures. And it's really, and I say that in a sense of, I am a product of, I'm a pediatrician, I'm a product of, I am a piece of, and I'm a consumer of this healthcare system. And I'm tired of not demanding and having equitable outcomes for all, including those who use drugs. So let's talk about the history of the healthcare system. We know about the racist history of the drug policy system, the healthcare system. I would argue most of us realize when people came over and discovered America that there was not a health and wellness approach to how we interacted with indigenous populations. So we can say from the institution of our healthcare frame, that was not our target. If we can't agree with that, again, we can have some conversations, willing to talk. But add into that, right, then we have slavery, and humans were truly disposable. Once you were no longer able to bring people over from West Africa, there was a little more healthcare because you had to keep your property alive. And particularly for pregnant and parenting women, maybe a little more healthcare, but it was decided not by you and not in partnership with you. It was in partnership with the slave owner, right? So that, I think we can argue that did not center health and wellness. And then we look back and we look at, okay, so we had segregated care for populations, but that segregated care was even harmed. One, either practices of indigenous populations or people from Africa were ripped asunder as we look at midwifery. There are many ways that people provided and had really positive outcomes for Black and indigenous women by providing midwifery, and this was ripped asunder by legislation, both federal and local, and by our public health infrastructure. So we took away access to health and wellness. We hindered the entry of professionals who could serve those populations because the white systems did not want to serve them, but we didn't even create and sustain professional organizations for the populations of color that sought to serve them. And then there was the Flexner report, which was a whole, which really you should read up on because it ruined all of your healthcare. But it really also sought to then close even more of those schools for people of color. And so then you look at drug policy and you say, well, like I said, addiction is a known health concern since Benjamin Rush, and there's many other people who have stated that. And we're going to remove drug policy from the criminal legal sphere, and we're going to put it into the healthcare sphere. And that should be a little concerning because the healthcare sphere didn't take care for people. It didn't offer wellness. It didn't offer holistic services for people who use drugs. It, in some ways, disincentivized. Dear Anslinger, who famous for drug policy, also really affected the healthcare provision for people who use drugs. When docs who were prescribing morphine and más o menos medication for opioid use disorder fashion were targeted, jailed, so disrupted that. But also the healthcare providers were brought up in the same racist drug policy system as everyone else. And so abdicated responsibility, felt that punishment was fine, and it was put over there. And if you put it over there, guess what? You're not teaching it within healthcare systems. You're not teaching how to provide equitable, culturally linguistically effective services for people who use drugs. And so even as the society moved to a public health or chronic disease-based approach, and I have some hesitation saying that because I think we talk about it a lot, but we haven't actually done it. But even as we do that, we don't fund in that way, and we have expectations that are difficult to meet. Because systems didn't serve people who use drugs, they don't know how to. You have to teach them how to provide services that are going to achieve wellness. Systems, as I said, were made up of people from the general public who had animosity towards people who use drugs. And systems were racist. I told you that history. This is not a system that embraces people. Right? It's not a system that was made to make sure that people of any type really have equitable outcomes, as we see by the statistics every day, from the maternal child health outcomes to heart disease. But it also truthfully was not centered to create wellness outcomes for people who use drugs, for people who are homeless, for people who have physical and other mental health concerns. So rethinking how we're going to do this really requires taking a deep look at these other systems and centering drug user well-being in these other systems by meeting people where they are, but by meeting people where society chose to cast them. And by this, I mean, there's places that they're always allowed, jails and emergency departments. We can admit that if we were there, that would achieve wellness. And places from which rules kept them out, be that employment, education, physical, mental health, and even our basic substance use services, which often were not evidence informed, often were very punitive, and often linked to outcomes that could harm as opposed to help. So you have providers and communities who said, we need to create a place to decrease the harms of drug use, because we admit there can be harms of drug use, and harms of systems that toward drug users. And this is where programs like ETS sit and continue to struggle. And even as the opioid crisis, and it's blatantly, I would say, different response based on the people who were deemed to have the opioid use disorders, and I say deemed to have because we all know that's not true. It changed only because of the face of the user, but the systems in place didn't achieve the outcomes that this public health system said it wanted to achieve, because we created systems from their inception that were harmful and weren't centered in creating care. And particularly for BIPOC populations and LGBTQ+ populations. And so it's this reason that groups like ETS are so important, because they connect all of these systems and engage with people and listen to patients and meet them where they are and build trust to provide culturally and linguistically effective outreach and engagement services, and then do their best to link folks to these other systems that have often failed them to achieve wellness, not just harm reduction. And I'm a deep believer in harm reduction, and harm reduction is covered in every other aspect of chronic diseases, but not just harm reduction, so people can be well and survive some days and thrive other days, but be here and be loved. So groups like EPS, though, they can't do it alone, and they shouldn't do it alone. It requires repeatable, reliable funding on par with services provided for other chronic diseases. And I want to be really clear here, as I rail on the healthcare system, this does not mean we're like, well, let's just keep people in those punitive systems till the healthcare system gets its act together. No. Again, criminal legal system, we can talk about it, harmful outcomes. Community-based health well-being is not going to happen in a system that doesn't center that. But what it means is increasing the circle of work and the scale of work that's currently done by communities led for and by people who are impacted by drug use, who had to save themselves while all these other systems were failing. It's supporting groups like ETS that have been in this space and increasing the circle of partners and holding one another accountable. So now I'm going to stop lecturing you, and I'm going to talk about some concrete things that I think we need to do as it relates to the healthcare system, which I guess is still a little bit of a lecture. But anyways, so healthcare system partnerships, we have to start talking about the healthcare system. The public health system is not the same as the healthcare system. Healthcare system serves to provide individual services. Public health is really about population services. But there is an opening now with that healthcare system that, as I told you, didn't learn how to take care of people who use drugs, but now they're being required to. There's movement afoot in the healthcare system that looks at outcome-based care. And others call it value-based care. I call it outcome-based care because I think it's really important to center that we're talking about outcomes, not saving money, but same thing. Maso menos, if you have the right heart and if you really want equitable outcomes. And this is a space where people are talking about outcomes-based care. Guess what? You won't achieve positive outcomes if you don't actually serve people who use drugs. And as I said before, I'm not just talking about substance use services. People who use drugs have been kept out of physical health services, mental health services, all other services that people need to survive and thrive. And they get to choose which services they want, but when you're kept out of all of them, you don't get to choose, right? And so really working to create contracted partnerships, and this is where many public officials, Medicaid officials, and others need to think about, what do those contracts look like? Not to reinvent the wheel, and this is really important, but really to achieve equity. What groups like ETS and other groups are already on the ground who have done this well and effectively? What can they teach us about creating those structures that are necessary to achieve the outcomes that need to happen? How can we partner and pay them to do this connection in these services so that we can achieve the the outcomes we want to see? And the reason they need to do this now is because these health insurers and health providers will only be paid if they achieve these outcomes. So they need to work in partnership, and there's a slow waking up call, but that is the only way that it's going to happen. So there's this opportunity and a need to partner with healthcare systems and healthcare advocates to make sure that becomes a reality, and that reality is equitable for all, and that systems are held accountable for these realities, which gets me to accountability, which is one of the topics I really love to talk about. And it really requires all of us to make sure these systems are continuing to achieve the outcomes that they say they want to. I think there's a couple frames that need to happen for you to have accountability. We have to rediscuss what outcome measures are. The outcome measures we have now are not effective for achieving wellness. Abstinence, recidivism, moving away from that, it reinforces the old thinking. We have to develop partnerships where individuals who take care of, work with, love people who use drugs are really going to say, these are the outcome measures that matter to us, these are the outcome measures that motivate us, and these are the outcome measures we want you to collect data on, analyze that data, disaggregate that data by who's in community and see where we're thriving or where we're failing, and then utilize that data in order to make changes. And it's really important that that data is used for good. There are huge privacy concerns because of the history I told you that we have where we punish people. This data needs to be used for good, it needs to be used in privacy methods, and it needs to be not used to re-stereotype and harm people. Utilizing that outcome and creating those outcome measures that are influenced and guided by people who use drugs, then can be used as a way to measure wellness and to hold systems accountable. So outcome-based measures, you have to know what measures you're up against and that you're achieving outcomes for. We need to define those measures, and they don't exist. This is where everyone's like, well, I want to do what Boo Boo's doing, or I want to do what DC's doing. I told you the history. They don't exist. We have to work in partnership to really create them. And we can. It's complex, but we can actually do that. And there's people who are doing that in similar fashion. There's this group called We in the World that is creating community-based and community-influenced outcome measures that they are then utilizing to work with governments in order to say, are we achieving the wellness that we seek to see? Not just is the hemoglobin A1C better for the diabetes, but are people thriving? Do they have social connectedness? Are they able to get and retain their job that they love? So really looking and thinking differently. The second set of accountability measures is around equity. And I think, we talk a lot about implicit bias, but a lot of this is explicit. This system was explicitly created to harm and keep people out. And then it became implicit as we pretended that that's not what the system was for. And so I think it really behooves us to really think about how we're going to really change and influence these systems to achieve equity. It requires education. It requires self-reflection and humility, but it also requires accountability. When you have the data and say that, oh my gosh, this particular provider is sending all the Black pregnant people who use drugs to jail and child welfare and all the white ones to treatment, that should be an aha moment that we need to work with that provider. And first you provide education, you create a performance improvement plan, but if it doesn't work, they may need to go. Because we actually say we want to achieve equity, we have to create the accountability measures to make that a reality. And the healthcare system in many places are building in these equity measures. And so, and I mentioned pregnant folks a lot because that's a passion place, pregnant and parenting women who use drugs. But in Pennsylvania, they're actually including in their value-based contracts equity measures to show that they are serious about people having equitable outcomes during this time period. And so I'm going to end with this, and it's a long ending, so beware. But I'm going to end with this. And in this work that we do, I think it's time also to assess the gaps. And the gaps that we see for people who use drugs, and they can tell you what the gaps are. It really requires, and this is something that's really fun at spaces like ETS. ETS isn't just about clinical services, and it's so easy. People really want to focus on clinical services, and they're awesome. And there's another reason they're awesome, because they actually provide methadone, which there's so much stigma about, and people don't like, but it's incredibly life-saving, especially now in fentanyl. So that clinical service conversation is one that needs to be had. But it's also about outreach. When you have history of people treating you horribly, shockingly, you do not trust those systems. I know that's probably but that's what any of us do. And so it requires people to come and meet you where you are and meet you where society decided you would be, and actually take the time to listen, take the time to care, take the time to hear who you are, what services you want and need, and work in partnership for that to happen. And then it is our responsibility in society to make sure those services exist, that they're culturally and linguistically effective, and that they're going to achieve the wellness outcomes that people need and they deserve. And I would say as a basic human right, though I did say that one speech and people said, what if you don't believe in human rights? And I don't have an answer for that. So get back to me on that. But I truly believe that people deserve this. And so with that, I just have this one quote that I ask us all as we think about where to move, what that means. And it's this great quote by this woman named Yaya Gyasi, who wrote a book called Transcendent Kingdom. And I'm just rapidly looking for it. This is what happens when you write your speech on chicken scratch. But what it essentially says is that we need to think differently. And it says progress in the sense of the natural way in which learning something new requires getting rid of something old. Like how discovering the world is round means you can no longer hold on to the idea you may one day fall off the edge of the earth. We need to hold the idea that we're doing something new. We're not going to fall off the earth. We can think differently. We can think about complex items, and we can work in partnership with groups that already had, because they were there to care and to love and to share when the rest of the systems didn't. And so it requires funding, supporting, and working in partnerships with groups like ETS to achieve the goals that we say we want to see, so we can truly work and love one another together. So with that, I'm done.